thank AIIMS Jodhpur and especially Alok for giving me this opportunity. Straightforward, going into the talk. Today's talk may be a little, people may not like my talk, especially the experienced minimal invasive surgeons, because in the first instance I'm telling, my incision is not small as everyone says 5 centimeter. It is a minimum of 10 centimeter incision. So I would just like to justify that in my talk. If anyone wants to criticize, fine. So that is what Alok told me to speak on minimal invasive in LV dysfunction. The first thing I would tell is please don't do a minimal invasive in LV dysfunction. So I would just like to show one of the videos where we could manage with some difficulty. So coming to the introduction, because of the rampant progress in PCI, surgeons are forced to take up minimal invasive surgery and also breaking their necks and backs. That is also part of the disadvantages involved in the surgery. So it avoids sternotomy, cosmetic, less blood transfusion, decreased ventilation, decreased pain. I don't know. I sometimes feel my patients get more pain. Decreased hospital stay, surely. Then, so the purpose of my talk is mainly for the beginners. I just want to show a few videos where they can get some tips. And the main thing, our purpose of a surgery should be, it should be equivalent to an open CABG. That should be our main purpose. What we have seen, many people don't talk about it. We keep hearing it when we are having a drink. Is that we can say we keep talking about less arterial grafts being used, vein grafts being used, or other things, poor graft patency, and when we talk to some of our students who are in the institutes, they keep telling us that we have done a study of redo CABGs and we had got so many from minimal invasive CABG and all, who had been done maybe 2 years back. So what I want to mention in capital letters is don't compromise on the long-term results of your CABG. So almost from 2007 or 8 when we started, I had been using a big incision and almost I am still in the same incision. Maybe it is 10 centimeter or sometimes 9 centimeter. And the next thing is do not do MIDCAB if you are having severe LV dysfunction, for sure. Emergency, don't do following PCI or any acute coronary syndrome, and if you are having a complex coronary anatomy. So these are like the absolute contraindications, because if you are having a occluded or a highly stenotic left subclavian artery, because when you want to do a total arterial, your inflow is always based on your internal mammary artery. So better don't do it to an open procedure, because you can use REMA as your inflow. In that case, severe COPD. Actually, patients with mild COPD are better candidates because their chest wall is so open, you have a lot of space to operate. But severe COPD, compromise in the pulmonary function, better not to do it. Emergency procedures and other things like I told, hemodynamic compromise. Comorbid situations like severe carotid artery disease, where you may have problem like if you want to go on pump, or intermittently if you are going into hypotension and all. Aortic atherosclerotic disease, because when you want to put a proximal, you have very limited area where you can put your proximals. Don't do it, because now we have faced problems. So that is why I want to tell all the beginners, no, never in your life try to do a minimal invasive with severe aortic atherosclerotic disease and all. The relative is severe obesity. These are all like, it can be we can say robotics can be used. So I am not going to talk about that. Severe chest deformity, complex coronary anatomy, and intramyocardial. Most of the time intramyocardial we come to know when we have opened the chest, and especially in cases where if you need endarterectomy of 1 or 2 vessels, because most of the CABGs we get are target, especially where we need endarterectomy. Small vessels also better to avoid. Diffuse disease, heavily calcified, highly tortuous vessels, and also instant stenosis, because sometimes the vessel is very much inflamed and you don't know which is the correct place to graft. Sometimes you may have to graft distally, or you may have to remove the stent. So these are all the situations which we should avoid. So these are the principles which I follow, our unit follows. Very careful selection, case selection. CT aortogram is a must. So we can do a TAVR protocol study where they do the complete aortic study up to the legs, so that you don't have any other surprises when you go for a femoral bypass or something. And if the patient has been studied earlier also, always do a echo the previous day evening, because we have seen fallen into problems because patient sometimes has got an echo 15 days back. He must have developed an MI or a pericarditis or inflammatory disease, pericardial inflammation. We don't know about it. We just take him and then we land in problem. Incision size is usually 9 to 10 centimeters for me. And why? Because we are comfortable taking out a long lima or a rima up to the bifurcation, and also we need a longer SVG. Venous graft, mark it with a pen so that you don't find difficulty in its rotation and all. And always use separate proximals for the right coronary and the OM. Don't use a single proximal. Y can be created for a vein on the left side. Suppose you have two vein grafts on the left side. Keep it as proximal, near to the proximal as possible, so that, or if you can do it as a separate proximal, also good. One thing which not many mention about or don't use is do a Doppler flow of your graft after you have finished the surgery.